Assalamualaikum and hi everyone. Today we are going to present about hypersensitivity mechanism. Our group consists of six members: NAZIHAH binti POZIAN, NURUL AWATIF binti MOHAMAD YUSRI, NURUL WAFA binti SOBRI, MOHAMAD FAREEZMAN bin ZAMZURI, and me Muhammad Nabil bin Razali, and Muhammad AMEER TAQIUDDIN bin MOHAMAD NOOR.
This topic consists of 6 parts. The first part is introduction of the hypersensitivity mechanism, and the following part is the categories of hypersensitivity mechanism, which are type 1, type 2, type 3 and type 4, and lastly is non-allergic of hypersensitivity mechanism.
What is hypersensitivity? Hypersensitivity is an immune response that mobilizes effector molecules. Effector molecule function is eliminate antigen through a variety mechanism. Supposedly, effector molecule will eliminate antigen without causing any significant tissue damage. Unfortunately, the inflammatory response or hypersensitivity reaction may be harmful and resulting in damaging the host, such as severe tissue damage, disease, and in the worst scenario, it will lead to the death. Hypersensitivity reaction is an immune response that causes exaggerate or unwanted reaction that are harmful to the host. It is a harmful immune response in which tissue damage caused by exaggerated or inadequate immune response in a sensitized person when exposed to the same antigen again. Hypersensitivity may include both the humoral and cell-mediated arms of the immune response. Hypersensitivity made of two parts. The first part is priming dose, or the first dose of antigen is needed to prime the immune response, immune system, and followed by the second dose, of the same antigen will result to the harmful consequence. Commonly, hypersensitivity has been widely divided into two types based on the time it takes to reaction to occur and the mechanism that causes tissue damage. The first type is the reaction occur within minutes or hours of antigen exposure, while the second type is the process takes by days to manifest the symptom. According to the Gel and Coombs in 1963, they divide the hypersensitivity reaction into 4 categories based on the 2 criteria. The first criteria is the time elapsed between antigen exposure, and the second criteria is the reaction and the arm of immune system involved. The 4 categories are type 1, type 2, type 3 and type 4. Type 1, type 2 and type 3 are antibody mediated and cause immediately hypersensitivity reaction, whereas the type 4 is cell mediated and cause delay hypersensitivity reaction.
Type 1 Hypersensitivity reaction. Introduction. The immune system plays a crucial role in maintaining health and protecting the human body against microbial invasion. However, the same system can lead immune and inflammatory response that result adverse outcome known as hypersensitivity reaction. There are 4 traditional classifications of hypersensitivity reaction, and these include type 1, type 2, type 3 and type 4 reaction. Type 1 hypersensitivity results in rapid clinical and underlies many disorders widely recognized as allergies, such as hay fever and asthma. In individuals to type 1 hypersensitivity, anti-agent exposure lead to LGE production. LGE bind Fc receptor on mast cell, packed with granules containing histamine and other performance mediators. This ultimately results in the clinical of type 1 hypersensitivity, which include rhinitis, asthma, and surface anaphylaxis. Type 1 hypersensitivity reactions are rapid, occurring with the minute after challenge. Production of LGE antibodies. When anti-agents enter into host, production of antibodies begins. At first, allergen is processed and presented by anti-agent presenting cells to CD4 T cells. Activate CD4 T cell divide from T helper cell and memory cell. T helpers produce IL-4. At the same time, B cell bind to antigen in presence of APC and IL-4 get activate. Activate B cell divide from plasma cell memory cell. Up to this step, mechanism similar to that normal humoral immune response. Etiology: the type 1 hypersensitivity occurs as a result exposed to an antigen. The response to the antigen occurs in two stages. Stage 1, the sensitization. Stage 2, the effect stage. In the sensitization stage, the host experiences anaphylactic contact with the antigen. Epidemiology: in this instance of type 1 hypersensitivity is hard to predict as differences occur in the assessment of the type of reaction. For instances, some document patients as having anaphylaxis reaction status post-milder system and other report anaphylaxis with a full-blown presentation. Pathophysiology: the type 1 hypersensitivity T cell then signal for stimulation of B cell to produce IgE antibodies, which bind to the Fc receptor on most cells and basophils. The free antigen induces the cross-linking of these mast cells and basophil-bound IgE antibodies. Histopathology: the histological appearance of type 1 hypersensitivity can be differentiated from others hypersensitivity reaction based on the type of cell responses. It has fevers and allergic asthma, neutrophils, and potential basophils are found in the mucosal or submucosal tissue of the respiratory tract and bronchial wall. History and physical: the initial step of diagnosing type 1 hypersensitivity is to obtain a full history from either the patient or patient companions. Information about the patient history should include signs and symptoms, timing, onset of sign system. In the patient is listed anything of new change trigger that cause the reaction, any prevention exposed to the allergen, prior history and allergic reaction. Treatment and management: the type of treatment provided the patient of type 1 hypersensitivity depends on the presentation and etiology of reaction. Anaphylaxis, epinephrine, bronchodilator, glucocorticoids, utacacrine. Complication: as previous stage, the most life-threatening complication of type 1 hypersensitivity is anaphylaxis, which can increase the risk of mortality. During an anaphylactic reaction, the patient may experience hypotension, difficulty in breathing, or hypoxia and of circulatory failure.
I'm going to share about type 2 hypersensitivity. Immune reaction categorized as type 2 hypersensitivities or cytotoxic hypersensitivities are mediated by IgG and IgM antibodies binding to cell surface antigens or matrix-associated antigens on basement membranes. These antibodies can either activate complement, resulting in inflammatory response and lysis of the targeted cells, or they can be involved in antibody-dependent cell-mediated cytotoxic ADCC with cytotoxic T cells, all of which lead to destruction of the cells. Parts of the complement activation can also opsonize the target cells on T8 for phagocytosis. The destruction of whole cells in this way can lead to tissue-specific damage. Type 2 hypersensitivity reactions may occur in response to host cells, such as autoimmune, or to non-self cells, or as occurs in blood transfusion reaction. Type two common type 2 hypersensitivities, which is hemolytic disease of the newborn (HDN) and hemolytic transfusion reaction (HTR). Hemolytic disease of the newborn (HDN) is caused IgG from mother crosses the placenta, targeting the fetus RBC for destruction. The sign and the symptom of the HDN is anemia, edema, enlarged liver or spleen, and more. While HTR causes IgG and IgM bind to antigens on transfused RBC, targeting donor RBC for destruction. The signs and symptoms are fever, jaundice, hypotension, and more. Transfusion reaction outlet. An inappropriate blood transfusion is administered and a patient is given blood not matching their ABO type. This led to activation of complement and widespread hemolysis by tumor necrosis factor and other interleukins which can be fatal. A person with type A blood has A antigens on the surface of their RBCs and will produce anti-B antibodies to environmental antigens that resemble the carbohydrates component of the antigens. A person with type B blood has B antigens on the surface of their RBCs and will produce anti-A antibodies to environmental antigens that are similar to carbohydrates component of A antigens. People with blood type O lack both A and B antigens on their RBCs and therefore produce both anti-A and anti-B antibodies. Conversely, people with AB blood type have both A and B antigens on their RBCs and therefore lack anti-A and anti-B antibodies. It is essential that the patient receive a transfusion with matching ABO blood type. A transfusion with an incompatible ABO blood type may lead to a strong, potentially lethal type 2 hypersensitivity cytotoxic response called hemolytic transfusion reaction (HTR). This is type 2 hypersensitivity hemolytic transfusion reaction (HTR). It is leading to hemolytic anemia. Blood type A donor is administered to a patient with type B blood. The anti-A isohemagglutinin IgM antibodies in the recipient bind to and agglutinate the incoming donor type A red blood cell. The bound anti-A antibodies activate the classical complement cascade, resulting in destruction of the donor red blood cell. This is type 2 hypersensitivity in pregnancy. There are diagram A and diagram B. In diagram A, when an Rh-negative mother has an Rh-positive fetus, fetal erythrocytes are introduced into the mother's circulatory system before or during birth, leading to production of anti-negative Rh IgG antibodies. These antibodies remain in the mother, and if she becomes pregnant with a second Rh-positive baby, they can cross the placenta and attach to the fetal Rh-positive erythrocyte. Complement-mediated hemolysis of fetal erythrocyte result in lack of sufficient cells for proper oxygenation of the fetus. In diagram B, HDN can be prevented by administering RHOD immune globulin during the after each pregnancy with an Rh-positive fetus. The immune globulin binds fetal Rh-positive RBCs that gain access to the mother's bloodstream, preventing activation of her primary immune response. Next is hypersensitivity type 2 in penicillin. Drugs such as penicillins can passively bind to erythrocytes. Antibodies directed against penicillin then leads to lysis of the erythrocytes. The formation of antibodies directed against the basement membrane of the glomerulus can develop during the course of kidney inflammation. Lung damage accompanied by pulmonary hemorrhage and renal inflammation may occur due to cross-reaction of these antibodies with the basement membrane of the lung. It is hypersensitivity type 2 in rheumatic fever. In this condition, antibodies are produced against group A streptococci that cross-react with cardiac tissues, an active complement and release of components of complement, which in turn causes damage of cardiac tissue. The treatment. There is no cure for these diseases. The treatment aims at symptom control only. Because of the pathogenesis of these diseases are antibody in origin, a lot of treatment options are aimed at that. Depending on the severity of the hypersensitivity reaction, different treatment approaches are applied. Treatment options, either given alone or in combination, include the following: steroids. The drugs include prednisolone, dexamethasone, and etc. In type 2 hypersensitivity diseases, sometimes high-dose steroids are used. Depending on the diseases, steroids could become a long-term medication. In such cases, long-term use will need medical supervision for monitoring of potential side effects. Other treatment methods all aim at altering the body's immune response. These include intragram infusion. Intragram infusion is infusing the body with antibodies. There are many potentially severe side effects due to this. Hence, it must be administered under specialist supervision. Next is plasmapheresis. This is removing the blood autoantibodies. And lastly, by using other drugs such as interferon, cyclophosphamide, and many more. Thank you.
Okay, for the next part is the type 3 hypersensitivity reaction mechanism. It is a reaction mediated by immune complex. Type 3 hypersensitivity reactions are also mediated by IgM or IgG. But in this case, the antibodies bind to free floating antigens which also soluble antigens and forming antibody-antigen complex. The complement system is activated and inflammation results, causing damage to the affected tissue.
Type 3 hypersensitivity is an immune complex disease where the tissue damage is a result of the inflammation induced by antigen-antibody complexes, also called immune complexes. Now, these immune complexes deposit in blood vessels or other tissues and organs, inducing complement and leukocyte-mediated tissue damage.
The mechanism starts when the complex become lodged in the basement membranes of tissue that have particularly high rates of blood filtration, such as the kidney and synovial joints that the common targets. Endogenous or exogenous antigen exposure triggers an antibody formation. Exogenous antigens are foreign proteins such as infectious microbe or a pharmaceutical product. Endogenous antigens are self-antigens against which the autoantibodies are generated, which is autoimmunity. In both cases, the antigens bind to antibodies, forming circulating immune complex, which can later migrate out of plasma and deposit in host tissues. Once launched, the immune complex rapidly and significantly activates the complement chain, causing local inflammation and also the attraction of leukocytes. The pathogenicity of immune complex is partly dependent on the antigen-antibody ratio. When the antibody is in excess, the complexes are insoluble, do not circulate, and are phagocytosis by macrophage in the lymph node and spleen. However, when the antigen is in excess, the aggregates are smaller. They freely filter out of circulation in organs when the blood is transformed into other fluids such as urine and synovial fluid. Therefore, immune complex affect glomeruli and joints. Activation of complement results in increased vasopermeability, the attraction and degranulation of neutrophils, and the release of oxygen-free radicals, which can severely damage surrounding cells. A typical example is serum sickness, induced by a large number of antigens in the blood. Therefore, the summary of what happened in type 3 hypersensitivity reaction is in 3 steps. First, immune complex formation. Second, immune complex deposition. Lastly, inflammation reaction. The principal factor that separates type of 3 reaction from other hypersensitivity reaction is that in type 3 reactions, the antigen-antibody complex are preformed in the circulation before their deposition in tissues. Type 3 hypersensitivity reactions are also called Arthus reaction.
In the type 4, it's called the self-mediated hypersensitivity or delayed type hypersensitivity. The short name of delayed type hypersensitivity is called the DTH. What is the DTH? It also known as a T-cell mediated hypersensitivity. The DTH causes by the inflammation resulting from cytokines produced by the CD4 plus T-cell and cell killing by CD8 plus T-cell. And then a hypersensitivity response mediated by sensitized TDTH cell which release various cytokines and chemokines. The DTH occurs 2 until 3 days after the TDTH cell interact with the antigens. We the type 4 have 3 subtypes. The first is granulomatous, tuberculin and contact dermatitis. Contact dermatitis is contact hypersensitivity dermatitis occur when heptane, which are considered as exogenous antigen, penetrate the skin with proximity to epidermal and dermal cells, resulting in an inflammatory reaction. And then the dermal, dendritic cell and Langerhans cell plays an important role in antigen presentation and sensitization of these heptanes to CD4 and CD8 T-cell lymphocytes. The latter secrete cytokines and other enzymes to recruit other immune cells to sites of heptane exposure. Additionally, the keratinocytes it helps in recruiting cells by secreting other group of cytokines such as IL and IL-8. This results in inflammation of the skin with swelling, itchiness and pain. Now we go to tuberculin. It can be seen after intermittent reaction of purified proteins directive for tuberculin. That produce measurable local induration and swelling, typically measured in millimeter between 48 to 72 hours after the injection. This local reaction indicates the presence of type 4 hypersensitivity. The tuberculin test is a valid method to diagnose tuberculosis infection even if latent. Granulomatous type hypersensitivity can occur in response to a variety of antigens. Macrophages that engulf antigen are unable to destroy them and recruit several more macrophages to the site of these antigens. A collection of macrophages filled with intracellular antigen is termed granuloma. One of the examples of granulomatous is sarcoidosis disease, which is a symptomatic granulomatous disease unknown causes with a wide variety of clinical presentations. Sometimes sarcoidosis is called reduced type 4 hypersensitivity due to the slow progression of this disease. Now we go to the DTH response has a two phase. The first phase is a sensitization and effector. The sensitization phase is occurs 1 until 2 weeks after the primary contact with AG. What happens during this phase? The TH cells are active and colony expanded by AG presented together with class 2 MHC on an appropriate species such as a macrophage or dendritic epidermal cells. Generally, CD4 plus cell of the TH1 subtypes are activated during sensitization and designed as a TDTH cells. now we go to the effector phase. Each occur upon the subsequent exposure to the AG. What happens during this phase? The DDTH cell secretes a variety of cytokines and chemokines which recruits an active macrophage. Macrophage activation promote phagocytic activity and increase the concentration of lytic enzyme for more effective killing. Activates macrophage are also more effective in preventing aging and function of the primary effector cells. The next slide is about protective role of DTH response. The first is a variety of intracellular pathogens and contact antigens can induce a DTH response. And then the cell harboring intracellular pathogens are rapidly destroyed by the lytic enzyme released by activate macrophage. And the last point is about detrimental effect of DTH response. The first point is the initial response of the DTH is non-specific and often result in the significant damage to health tissue. In some cases, a DTH response can cause such extensive tissue damage that the response itself is pathogenic. Example, Mycobacterium tuberculosis, and accumulation of active macrophage whose lysosomal enzymes destroy healthy lungs tissue. In this case, tissue damage outweighs any beneficious effects.
Non-allergic hypersensitivity. Non-allergic drug hypersensitivity, also known as pseudo-allergic or anaphylactoid reaction, have clinical symptoms that can be confused with allergic reaction. Non-allergic drug hypersensitivities do not include either IgE mediated, which is type 1, or delayed hypersensitivity, which is type 4. Pseudo-allergic. Pseudo-allergy, also known as non-allergic hypersensitivity, clinically mimic immediate type allergic reaction but lacks evidence of underlying immunological mechanism. Aspirin and other non-steroidal anti-inflammatory drugs, as well as certain food ingredients and additives such as salicylates, benzoates, and tretazine are the most common causes of pseudo-allergic reaction. Chemotherapeutic medication, radiocontrast agent, vancomycin, non-steroidal anti-inflammatory agents, local anesthetic, reaction, and opiates are the most popular non-allergic drug hypersensitivities. Most protocols for skin testing with radiocontrast, non-steroidal anti-inflammatory agents, local anesthetic, and chemotherapeutic agents have not been tested or standardized. Other diagnostic tests include in vitro IgE test, and the new gold standard is typically an oral challenge or bronchoprovocation test. Even though aspirin is not thought to be IgE mediated, a desensitization protocol has been developed and successfully used, though the mechanism of this desensitization is unknown. There are testing methods for distinguishing between allergic and non-allergic medication hypersensitivity reaction. Avoidance is the best option in non-allergic drug hypersensitivity. If that is not feasible, pre-medication protocols have been established, but their effectiveness varies depending on the drug and the patient.
That's all from us. Thank you for watching.